We will now proceed to our next presentation on exploring avenues to enhance American Indian, Alaska Native information sharing. We are honored to have two distinguished speakers joining us for this topic. Dr. Daskalakis, Director of the National Center for Immunization and Respiratory Disease at the CDC, and Dr. Wharton, Associate Director of the Vaccine Policy and Executive Secretary of the Advisory Committee on Immunization Practices. So welcome.
Great. Thank you so much. Thank you so much for having us. I was able to be here for most of the morning until I got pulled in a couple of directions, and I'm so grateful for the invitation, and also so grateful to spend time sort of hearing from you and really interacting. So I'm excited for the next part where I actually get to talk to you as opposed to just listen, which is great. And then I'm looking forward to sort of your insights and again, really so happy to be here. And we all love Les. Thanks, Les. Amazing. So next slide, please. So what we're going to do today is really, I'm going to start and I'm going to then pass the baton over to Dr. Melinda Wharton. I'm going to be talking a bit about NCIRD, the National Center for Immunization and Respiratory Diseases. And then Dr. Wharton will then take a deeper dive into ACIP, and you'll learn all about that in a moment. Next slide, please. So a big overview of what we're going to do. Again, a little background on NCIRD, as well as sharing our priorities, which I hope you will see your community in, and would love to sort of get your perspective and feedback on that as well. We'll then move to Dr. Wharton, who is going to talk about the ACIP policy formulation process, as well as recent developments related to American Indian, Alaska Native recommendations, as well as discussions with you about better info sharing. So that is the lay of the land of how we're going to sort of run this section. Next slide, please. And so I'll start, as promised, talking about NCIRD. And so first, we'll take the aerial view of what is the National Center for Immunization and Respiratory Diseases by really looking at its mission. And so the mission is the prevention of disease, disability, and death through immunization and control of respiratory and related diseases. Challenges include that we have both a domestic and a pretty significant global footprint, really interacting closely with our colleagues in the Global Health Center. And then also accommodating all populations at risk for vaccine preventable diseases, and really thinking about this, from the entire lifespan view. So from newborn all the way to nursing home and beyond. So we will always point you toward a very robust website. So you can take a look at our website at NCIRD for more details and a deeper dive. Next slide, please. So in terms of the how we actually implement this mission, we're going to go over some of our core strategies. So we work to provide leadership and expertise in service in lab and epi sciences and in immunization program delivery. So I'll stop for 1 second there and just say, NCIRD has a couple of different characters in terms of how it works. So we support vaccination programs throughout the country through health departments. We also support guidance around vaccination, but then also really are responsible for monitoring many of these diseases, as well as pushing the envelope on the science, both epidemiologic and laboratory. We conduct focused and applied research specifically on prevention and control, and that really ranges from diagnostics all the way to exciting new vaccine platforms that could change the way that vaccines are administered in the US and beyond. We then have a very clear process of taking not only our research findings, but other research findings quickly into public health policies and practice. And I think Melinda will give more of a flavor around that when she talks about ACIP. We are also a service organization and provide diagnostic and reference laboratory services to some partners. Part of the work that we do is to conduct surveillance. Surveillance is a strange word. So what we do is monitor what's happening with the diseases that are within our center, and then also focus on research that, again, goes from very operational research all the way to the most basic of basic science. We not only do sort of the work here, but also through collaboration with our partners, respond to disease outbreaks. And we do this both domestically and abroad. And I'll say recently, I got to travel to Asia and sort of see the team in action responding to avian influenza in Cambodia. And so really a broad view. And so in the US, that often means providing really significant technical assistance to local health departments so they're able to deliver on outbreak response, and occasionally also, if they need, additional resources. Ensures that public health decisions are made objectively and based upon the highest scientific data. We'll deeper dive into that with ACIP. Also, we are responsible for having some of the world's experts, and by having world's experts in immunization and respiratory diseases, we provide technical expertise, education, and training, not only to domestic, but also international partners. So again, that scope is pretty wide. Next slide, please. But it doesn't end there. We provide leadership to internal and external partners for establishing and maintaining immunizations. We develop, implement, and evaluate domestic and international public health policies. And so again, you're going to hear about ACIP, even where we don't necessarily touch global. Sometimes what we say and do through our collaborations and through our policy development ends up influencing what happens around the world. We also are responsible for communicating information so that we can increase awareness, knowledge, and understanding of both public health issues regarding our areas internationally and domestically. And embedded in that is also communication to not only improve confidence in one or two vaccines, but to improve confidence in vaccination period, which is like one of the key missions of NCIRD. We obviously work within a wonderful organization. And as you've probably heard, like we're really taking a one CDC strategy. So we really work to align our focus with what the larger priorities are of the director as well as the whole agency. Though we're not alone in this, we are also a really significant part of the synchronization of CDC's pandemic preparedness and response. So that really scopes from strategy to actual response. So really important that we're a part of that discussion. And that's another one CDC moment that we work across the agency. And then also we implement, coordinate, and evaluate programs across our center and CDC. So you'll hear a little bit about VFC as an example, Vaccines for Children, which is a massive program that really supports prevention in over 50% of children. And there's a very specific component that I think is important to the American Indian Alaska Native population, which we'll go into. So really a great program that we implement, coordinate, and also evaluate. Next slide, please. So now going a little bit closer to what are our more short to medium term priorities, I'll start with a really important one that I think is really instructive for all organizations that have been through the pandemic. We're taking a step back and we're looking at our own organizational health, thinking about ways that we can modernize our structure and the way that we operate, but also identifying ways that our organization can work as a thriving organization rather than one that is only responding to challenge and trauma. And so I think we're taking a lot of work into that space, and that actually then permeates into all of our other priorities. Not surprisingly, September, October, November, December, January, February, and March happen every year. And so we're working to establish a really clear readiness structure that is for the routine respiratory season, realizing that every routine respiratory season often has things that happen within it that are not routine. So also having space for those wild cards that when we are hit with things that we don't expect. But really, how can we make this really routine and as transparent as possible in terms of what the expectations are? The third mission really plugs into everything I've said before, which is that we're really here to establish equitable access to vaccine in the US. And the importance of that is not just in children, but across the lifespan. But we are also very specifically focused on children and adults around the issue of catch-up vaccination. And so what I mean by that is all vaccines took a hit after COVID-19 emerged. And so we have some work to do to catch up. And so as well documented in the news, we're seeing sort of outbreaks and cases of measles around the country. That's really driven by unvaccinated folks. So really important for us to sort of work on the catch up. Next slide, please. So thinking about equity, one of our very important populations that we focus on are pregnant people. And we're looking at how we can improve the platforms that we have to look at maternal or vaccinations in pregnant people, not only to assess safety, which we already have some robust systems, but also outcomes both in the pregnant person as well as their newborn. So really exciting, given that we have a lot of products that exist and a couple that are in the pipeline that really focus on vaccinating the pregnant person so that we can protect the newborn. And then finally, and this is like a lot of sort of acronyms, so I'm not going to read all of the acronyms, but working across the US government so that we can help accelerate diagnostics. So how can we get tests that people need, whether it's in the public health arena or the clinical arena? How can we be a part of the pipeline so we can move them faster and improve people's awareness from the clinical perspective as well as public health? Next slide, please. So I am going to read every single box. No, I'm not. So this is our organizational chart for NCIRD. And I just really wanted to highlight that we have 5 divisions. I'll also highlight that 4 of the divisions have an overt global component as well as domestic. So our divisions are influenza division. So that division is really important globally, not only domestically, because we do the lab work and have the connectivity in the world to be able to help with strain selection for the flu vaccine. So the work that we do at this campus that connects to the entire world actually is important in how we figure out what the next vaccine is going to be. We have the division of viral diseases. So that division covers a lot of diseases that you're well aware of. I will say measles is one of them that we cover, but also polio and a lot of other infections that are urgent, emergent, or re-emergent. Division of bacterial diseases, lots of work, again, both domestically and globally, thinking about pneumococcus as one example. So one of the bacteria that causes pneumonia and other invasive diseases, meningococcus, so like one of the bacteria that causes meningitis. These are all in that wheelhouse. And introducing our newest division, which is CORVID, coronaviruses and other respiratory virus division. So this division focuses on COVID as well as other viruses, RSV, respiratory syncytial virus is an example, but really also in a very similar frame to influenza division is really helping to make sure that we make the right global selection for COVID vaccinations so that we're ready to go for our next update of that vaccine. The last division is the Immunization Services Division, which houses vaccines for children as well as a lot of other really important work around surveillance and vaccine implementation. And they do not have a global footprint. They're very domestic, but what they do, people watch, and it has has global influence as well. Next slide, please. And just a couple of highlights in terms of programs that I wanted to highlight for us here is our Immunization Gateway. So this is one of our programs that really helps improve the way data flows so that we are better able to really track as well as let people access their own data around immunization coverage. I wanted to highlight that we specifically have contracts in place to provide technical assistance to IHS to onboard this very important gateway, and really it will be really important in improving preventative services and health in AIAN populations. And then also, this is what I said I was going to highlight at the end, is that our Vaccines for Children program, it doesn't just cover COVID-19 and flu, it covers all of the recommended vaccines from the Advisory Committee on Immunization Practices, ACIP. You're going to hear a lot more about that in a moment. But one of the important things to remember is that VFC also covers all AIAN children who are under the age of 19. They are all eligible and are able to access vaccine at no charge. I think I now hand it over to Melinda, Dr. Wharton. Next slide, please.
Thank you, Demetre. Next slide. So I have the privilege of serving as Executive Secretary of the Advisory Committee on Immunization Practices, which is a federal advisory committee that provides advice to the director of the CDC on the most effective means to prevent vaccine preventable diseases in the United States. So the committee makes recommendations on vaccines and some related products like immune globulins, and that would include the long-acting monoclonal antibody that was licensed last summer, nirsevimab. And of course, most of the products that ACIP makes recommendations for are FDA licensed products, but when the circumstances warrant it, like during the pandemic, ACIP also can make recommendations for unlicensed vaccines, vaccines that are available under EUA, for example. Can we get back to the slide? Go back a few more. I think that's it. Okay. Forward one. Oh, no, here we go. Okay. So for the products that ACIP considers, they provide guidance to the agency on who should get it, under what circumstances it should be used. And they consider a number of factors in making these recommendations. That includes the epidemiology of the disease, how much disease there is there enough disease that it's worth having a large program for prevention? How well does the vaccine work? What's the effectiveness, duration of protection, vaccine safety, the quality of the evidence reviewed, economic analyses, and implementation issues. Do the characteristics of the product actually allow it to be used in an immunization program? Next. Traditionally, the committee has met 3 times a year. Those used to be 2-day meetings. Recently, we've had a number of 3-day meetings. Our meeting that's next week will be 2 days. I'm pretty sure the one in June will be 3 days, just because there's a lot of things the committee has to talk about and make decisions on. But during the COVID pandemic, there were many more frequent and extra meetings to address both COVID vaccine issues as well as other issues that required addressing outside the normal 3 meetings a year. We did have a couple of extra meetings last summer for one for COVID and 2 for RSV prevention products. One notable thing about our committee is that the meetings are open to the public. We webcast them so anyone in the world can watch them. And for meetings that are making really big decisions, there may be tens of thousands of people from all over the world watching. And certainly for individuals who are interested, it's easy enough to go onto the ACIP webpage and watch the meeting while it's occurring, or if you want to watch it later, the videos are posted on YouTube. During the live meeting, we do have oral public comment, which is scheduled at every meeting at which votes are taken. And there has been increased public interest in providing public comment over the last few years. We also receive written public comment through a published docket on regulations.gov. And again, individuals and organizations who want to weigh in on issues coming to the committee can submit that written public comment to the committee through regulations.gov. The information about the committee is available on the web, and you can see the link there. And again, when our meetings are occurring, you can actually watch the meeting on that webpage or on the ACIP website. Next. The committee, under our charter, we can have up to 20 voting members. We're not quite there at the moment, but the committee should have a consumer representative and then other members with expertise in specific disciplines like pediatrics, public health, immunology, nursing, different disciplines. We aim for 4-year overlapping terms, so there's not too much turnover in any given year. And we screen for conflicts of interest and at the beginning of a term annually and at every meeting. And notably, although I guess there's a couple of CDC employees in that photograph there. ACIP is independent of CDC and voting members are not CDC employees. They're members of a federal advisory committee. Next. We do have ex officio members who represent other government agencies and offices. And this helps bring perspective across the government from FDA and CMS, Indian Health Service, NIH, HRSA, and the Office of the Assistant Secretary of Health. The members of these organizations participate on work groups and participate in the meetings. Next. Also, there's a larger group of organizations that participate as liaison organizations. And these are organizations with broad involvement in immunization, who have a designated representative who brings the perspective of their organization to the ACIP's deliberations. And we expect that these organizational representatives will keep their organization and their organization's membership apprised about ACIP's deliberations and recommendations. Many of them do serve on work groups and participate in, and they should all be participating in every ACIP meeting. Also, some organizations sign on to our updated immunization schedules every year. Next. Although we have these very intense public meetings, which, kind of look like the meeting you all are having right now, there's a lot of work that goes on behind the scenes in our ACIP work groups that isn't visible. These subcommittees provide an opportunity to provide in-depth review of the information available and really pull it together in a comprehensible way for the committee so that in a session of an hour or two, they can actually get a very good view, a very good summary of a whole lot of work that was done by the work group. CDC organizes those work groups and manages their work. And notably, the work groups don't make recommendations to CDC. Only the whole committee can do that. Next. Now, there's a couple of things that have happened recently that may be of particular interest to you. In August 2023, ACIP recommended nirsevimab, which is a long-acting monoclonal antibody product for prevention of severe respiratory syncytial virus. And that was recommended for all infants during their first RSV season and for infants 8 to 19 months of age who were at increased risk of severe RSV during their second RSV season. And among the infants who fell into that group at increased risk were American Indian or Alaska Native children. So there was a recommendation that recommendation for use in the second year of life included those children. The need for tribal engagement on this was not really recognized until very late in the process. And we clearly should have done it sooner. It was done kind of at the last minute. We appreciate the help of OTASA in allowing us to do that, albeit in a sort of abbreviated and rapid way. But with a more recent question, we did have a listening session back in January that included more than 60 participants who asked good questions about use of the vaccine, about adding to the existing preferential recommendation for one specific HIV vaccine product, whether that preferential recommendation should be extended to a combination product that includes that HIV vaccine product. Because American Indian and Alaska Native infants are at risk at an earlier age than some other children, this one product has been preferred because it provides protection earlier. And now there's evidence that the combination vaccine can also provide that protection earlier. And so ACIP will be discussing this and making a decision on it. And the information and feedback we got during the listening session will help inform that discussion for the committee. Next. And here's what I just said. So in January, we did have a listening session in conjunction with OTASA. there were representatives from tribes, tribal serving organizations, and IHS. And there were, again, active participation, engagement, questions about the policy change. And this discussion will be incorporated into the subsequent presentations before the committee. Next. So we're actually, I'd really much like to hear from you about how we can do a better job of sharing information and getting input on the committee proceedings. It is not frequent. There are specific recommendations that are specific for the American Indian Alaska Native population, but it does happen occasionally, and I gave you 2 examples. But of course, the recommendations of the committee impact everybody in the country. And there's a variety of ways that we interact with individuals and organizations. I gave you examples of some of them, but we'd really welcome any thoughts, questions, feedback, or questions from you right now. So thank you very much.
Thank you, Dr. Daskalakis and Dr. Wharton, for your insightful presentation. Now I'd like to invite all TAC members to share any further questions or comments regarding the Exploring Avenues to Enhance American Indian Alaska Native Information Sharing presentation. The floor is open for discussion. TAC members attending the meeting virtually, please use the raise your hand feature or place questions in the chat box. When you speak, please remember to state your name twice in the area you represent to ensure accurate note taking. So I'll turn the floor over to TAC members for questions or comments. Yeah, Ms. Freeman.
Carrie Freeman, tribal at-large member. So have you changed your process on getting tribal engagement earlier? As you stated, you realize that it should have happened a little earlier. Moving forward with anything that emerges in the future, like, is that part of your process and planning now?
Yes, thank you. Thank you for asking that question. Actually, the team from Motasa will be talking to our ACIP work group leads on Monday and providing the background on the, sort of why this needs to be done, and we need to build it into our process. And certainly we will be alert to this issue in the future and collaborate with our TASA on the specific processes that they use going forward.
I have a question that may not quite be related. Back to the vaccines for children, it may not be related to American Indian and Alaska Native children, but it may affect them. And this may not even be a question you can answer, but what is the CDC doing about immunizations for immigrant children who are coming into the United States, who maybe have not had immunizations yet? How are we protecting our Native American, Alaska Native children from diseases that may be brought in from immigrant children?
So I'll start in terms of sort of the eligibility requirements for vaccines for children. Really the eligibility really focuses on like their insurance status, what insurance product they have, and their age. So that means that that this resource is available and is used with recent immigrants when it comes up. So that's an important sort of component of this. In terms of the work that happens on the sort of VFC side, the global effort of VFC is to improve coverage of all of the ACIP recommended vaccines in populations. And again, there's that specific focus on American Indian, Alaska Native populations. And so a lot of the work that looks like it's just about build it and they'll come, sort of providing vaccine, is actually then backed by a lot of additional work to improve confidence and access just beyond here's the vaccine, but also with provider education and connectivity to make sure that we are improving coverage across the lifespan, and very specifically in kids through the VFC program.
Thank you.
Thanks.
Thank you both for a great presentation. I would like to ask a question that's kind of focused on the structure of the organization and how different parts work together. I'm thinking specifically, Dr. Daskalakis, on how we are engaging tribes in our plans for potential listening sessions or at some later point, tribal consultation. Could we go back to the slide that has your org structure? It was a few slides. It was earlier in your presentation. Who's controlling the slides? Okay, if you could go back to the structure. In the center, I noticed you have the, let me see, influenza division, you have COVID, and then there's a respiratory, division of viral diseases.
Yes.
And then there's the immunization.
And
I'm trying to
division-
remember all of them.
You're good. You're good. You're
Am I
close
doing
there.
pretty
So we have
good?
5. So that was pretty impressive. So the 5 are flu, COVID, DBD. This is why you had the thing. That's bacterial diseases, and
Right.
VD, which sound alike, but they're different.
Right.
And so we have those programs that really, I would say focus on some of the science and some of the policy and some of the sort of specific work for the organisms that they sort of own in their world. And then the Immunization Services Division, they're kind of our like operational component that really touches the sort of the front line. And so, very often there are issues that may sort of touch the American Indian, Alaska Native population that sort of live within one of the divisions. Like, let's say we just hit one now. So Haemophilus influenza, as an example, that lives in our division of bacterial diseases. But the implementation and some of the additional work moves into the Immunization Services Division, which interacts really closely with ACIP that really sets policy. So it's all of the parts, though it looks like it is both wide horizontally and tall vertically. There's a lot of cross-linking in terms of how the actual sausage is made, like how we move from like ideas and science into actual policy and implementation. Did that answer the question?
It does. I was thinking specifically about some of our touch points, the touch points between NCRD and OTASA.
Yeah.
And there may be many areas across the center where we can work on things
That's right.
together to engage our TAC or even expand that engagement. And so we can talk offline, but
Yeah.
I thought it was important to share with this group to highlight that this is a center that touches on very quite a broad spectrum of activities that we would be engaging on and can do so through OTASA. And they have a coordinated approach for doing so.
Yeah.
So thank you.
Try our
for
best,
sharing
and
that.
we'd love to knock on your door for help. So thank you.
Ms. Frias, did you have a question? Okay.
Yes, thank you for your presentation. Herminia Frias, delegate at large and also council member for Pascoyaqui tribe in Southern Arizona and Arizona. I just want to refer to the vaccine for children and what you commented on catching up. And what some of the issues around anti-vaxxers and some of the disinformation that's out there and how we can go on giving factual information and ensure that people are getting the right information. So, how we can do that in our tribal communities, because we also face that. A lot of times we think that we actually have a pretty good rate, I think, when it comes to vaccine rates in our tribal communities, but we're starting to see that, we're starting to see a difference now, with that anti-vaxxers. And also, it also affects our employment because, people that decide not to vaccinate, maybe people that are working with us. It affects people that even people that, we're just starting our childcare center, but tribes that have childcare centers, that children that are not vaccinated, we have a Head Start. How it affects our school systems, how it affects, so this is a real issue of ensuring that our children are vaccinated, and especially some of the children that, previously were vaccinated, but now some of the parents are choosing not to vaccinate because they're getting information that is not factual.
So thank you so much for your question. And I feel like this is the stuff that keeps us up at night. So I'll start by saying that. First, I'll say, sort of as a sort of CDC representative, like there is so much work happening on the agency level, not just within our center, about sort of addressing mis and disinformation. So I think it's a really important sort of piece of work that really helps us going forward, because I think it is important to say out loud, we're going to have a rough time. And I think it's because, I think people are thinking of vaccines and vaccination in a way they never have before. Components of this have been politicized. Components of it have been fraught with mis and disinformation. So the work that we do at the agency is critical. And then also diving deeper into the work that we do within NCIRD, not only to think about the mis and disinformation, but how to just build up general confidence. So when we think about our ISD, our Immunization Services Division, as well as our other core divisions, a lot of the work that we're doing is really figuring out how we can provide materials and information that is actionable and usable by our partners. And so, we would love to keep this dialogue going, because I think that one of the ways that we can fight mis and disinformation is to saturate the system with good information. And we would love to be your source of that good information. So, and thank you.
Yeah, and I think part of that, what's important to have is, especially with our tribal communities, is to have the leadership and trusted people in the community that can support that.
Yeah.
That they're hearing from trusted people in the community that are saying it's okay.
Yeah. So I think we saw that play out in COVID, I think, over and over again. And I think part of the work is to really make sure that we identify folks who are trusted partners and trusted communicators. And then really, I think the really important part is that, again, and the more you can help us, the more we can do, is sort of identify who is the trusted source of information. And again, I'm going to say it's us in terms of the expertise, as well as information that really supports vaccination. So any opportunity that we have, any sort of partners that we can connect with and provide really good information to be able to sort of support this effort. Because I want to go back and say it is going to be an uphill battle, especially when, and not to sort of go too long on this, when the difference between like having a good amount of protection in the community to not having enough sometimes is like 1 or 2 percentage points in coverage. Like it's not like, oh, it's 20% now and it was 80%. It's like if we lose a little bit of ground, we're going to see measles outbreaks. We're going to see, more of the things that we don't see very often. And so I'll double click on what you said and agree that it's not just about the materials, but also about who's delivering it, because there are definitely circumstances where I may be a great messenger and definitely circumstances where I'm not the person that people want to listen to. And it's really important for us to know that and really not sort of use people as tools, but to bring them into the story. Because I think, and I know especially from my interactions with tribal communities, there's such a community of making sure that there's support for the health of the community. It's such a core value that I think your partnership with your leaders is critical in what we do. So thank you.
Yes, Ms. Russell.
Thank you, Ms. Barker. My question is around what sort of strategies or work you're doing to improve vaccine confidence within American Indian populations. Do you have any sorts of tribal specific campaigns that you're considering putting together, of course, with tribal input? For my community, we're at least with the COVID vaccine, we're recognizing, of course, in the beginning, a lot of us were taking the vaccines, but over time, and I'm certain it's in other populations, it's really decreasing into a very significant amount. And the vaccines for children that you brought up, we're having a welcome home baby event in April. And we're copying another tribe. I can't remember what tribe, but our first lady of our nation saw what they were doing and she just had a baby as well. So really trying to bring a focus to maternal and child health within our tribe. And so this is kind of really current for me. But the other one would be maybe a campaign, not only vaccine confidence, but, the catch up on vaccine. What sorts of materials could you put together, of course, with tribal input? Because for my community, it's going to be, these materials that we need. For us, we're very rural. Internet is not a primary way that, well, we do communicate that way, but it's going to be the written, materials that we need to put it out there. The other way that we communicate for My Nation is largely on radio as well. So that's my question in regards to improving vaccine confidence and any sorts of tribal specific campaigns.
Great. No, thank you. And thank you for the question. So I'll start by talking about sort of a new piece of work that we're moving on, which I think is really exciting. And I think you've already heard about a product called Nirsevimab, which is a monoclonal antibody, which is an immunization. So it's not a traditional vaccine where we give a shot and the person's body then responds and creates protection. It's providing an antibody that just pretty much is protective from the moment that that child gets the vaccine. So we have this new immunization called Nirsevimab. It protects against respiratory syncytial virus, and we're actually launching some very specific engagement in tribal communities so that we can see how between that product and the new maternal RSV vaccination, how we can improve uptake given also the high burden and high morbidity of disease. So this is a space to watch. So watch this space we're at with us as we move forward. I'll say also your concern about new young families is also one of the core priorities at CDC. And this sort of work specifically with American Indian, Alaskan Natives falls within that broader CDC priority, just sort of demonstrating the sort of fact that, we plug into the bigger picture of what folks are interested in and what's prioritized at the agency. Sort of we can do better and more in terms of getting our materials reviewed and also get the feedback to make sure that we're responsive to what the needs are, and look forward to more conversations to be able to do that better. Because I think, part of the confidence issue is providing good information, but also in a way that's digestible to the populations that we're trying to reach. So a little bit of watch this space, a little bit of exciting news in terms of RSV, the RSV program, and then more to come. Thank you. And I hear you on the radio. That's really important. Thank you.
Anyone else?
Yeah, Odin Kirchen, and one of our national partners on IHP actually did receive funding for vaccine confidence. That funding goes through the end of July. So it is possible that you could reach out to them for some of those materials as well. In addition, NIHB is also putting on some vaccine clinics. So you might want to reach out to them to see if it's also possible to get involved in some of those activities as well. So I just wanted to make sure that the TAC was aware of that. Thank you.
Thanks.
Thank you for those comments. And thank you, NIHB. Okay, anyone else? Okay, if not, thank you both again for your presentation. Very informative.
Thank you for
Thank
having
you.
us.
Great, thank you.